Hi, everyone. Good morning, good afternoon, wherever you're joining from. We're glad that you're here today. I'm Jasmine West, she, her pronouns, manager on NASTAD's hepatitis team, and welcome to day 2 of this virtual convening, Unlocking HCV Care in Key Settings. Next slide, please. So this event is a greater part of the CDC-funded cooperative agreement, the Hepatitis Network for Education and Testing, aka HepNet. It's a 5-year project. We're approaching year 3 with our partners, NVHR and HO, as we build out this network of public health stakeholders. We have CBOs, tribal health organizations, state and local health departments, people with lived experience, healthcare providers, and you name it, you can be a part of the network. But as we build this out, the idea is that the impact of this network is to bridge the gap between hepatitis programs and harm reduction programs, centering health equity and providing the tools and supports to contribute to the elimination of viral hepatitis among PWID. Next slide, please. So the purpose of this event is to bring together hepatitis C subject matter experts to identify effective strategies to increase nationwide HCV testing and treatment in key settings. Those key settings were identified as MOUD treatment facilities, state correctional facilities, FQHCs, and SSPs. During each panel, we're asking ourselves, what are the barriers, what are the optimal models of care, and what partners, platforms, and strategies can be used to scale HCV testing and treatment in each of these key settings. So we had a tremendous wealth of knowledge from our moderators, panelists, and other subject matter experts yesterday. We have the same going for today. And all of this information is going to be summarized into a meeting report that's going to be made available to everyone on this call, everyone in your network. Folks will have open access to this report that summarizes these key strategies to increase HCV testing and treatment in the key settings that were mentioned. Next slide, please. So yesterday was day 1. We heard from experts from the MOUD and state corrections panelists. It was a really great, profound first day. So whether you joined yesterday and are joining again today, welcome back. Or if you're joining fresh today, welcome. We have another excellent round of sessions in store. Next slide. We're currently in the welcome part of things, so welcome. We will move into our FQHC panel here shortly, have a 15-minute break, and then spend the rest of the afternoon with our SSP panelists before wrapping up the day and synthesizing evidence-based practices for all of the key settings. So with that, I'm going to turn it over to my dear colleague who has helped spearhead this event, Daniel Raymond, Director of Policy at NVHR. Next slide.
Thanks so much, everybody, and welcome or welcome back. Just a few housekeeping tips. Participants are in listen and view only mode, but we really do want to hear from you. So we have a Q&A box. You'll see that button in the middle of the bottom of your Zoom window. And if you have questions throughout the session, submit them through the Q&A box. We have carved out ample time for discussion and Q&A for each of the panels, and we will try to get through as many questions as we possibly can, but all of the questions that you submit will ultimately help to inform the final report that we release. So thank you for everything that you're contributing to this. And will the recording be available? That is a popular question. The answer is yes. We are also aiming to get the report that Jasmine mentioned disseminated in October. Wherever possible, when we have speaker permission, we will also make slides available after the event. And importantly, we really do want to hear how useful this was for you, how you're going to use this. So stick around. There will be a link to a quick and relatively painless, but hopefully informative evaluation at the end, just so that we can keep track of how we did and what other things we can keep refining. Next slide, please. So this is the slide of my heart, the acknowledgement slide. It took a vast team to put this together. From the NVHR side, aside from myself, Adrian Simmons, who's on, has been instrumental. From the NASTAD team, Watman Thierry Reed, Isabella Chuga, Jasmine, of course, and Sakia Grubbs, and many, many partners from CDC's Division of Viral Hepatitis helped shape, inform, and guide this project. Carolyn Wester, Dee Bixler, Karina Rapistelli, Mona Deshani, Nathan Furukawa, Pam Lemos, Talia Pindick. And we really would not have been able to put this on without the support from CDC. Funding for the meeting is made possible by a cooperative agreement, National Viral Hepatitis Education, Awareness, and Capacity Building for Communities and Providers that was awarded by CDC. This is the award that overall funds and informs the HepNet project, and we're really grateful for CDC's support. Of course, the views expressed in this discussion or future publications by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. So with that disclaimer out of the way, before we move into our first panel on community health centers, we wanted to invite our CDC colleague, Nate Furukawa, back. He opened our day one with a really nice overview, and we're going to ask him to recap a few of the pieces that will be relevant for this afternoon's discussion. So I will turn it over to Nate.
Hey, thanks, Daniel. Yes, so could I have the next slide? So if you all were here yesterday and got this presentation, wonderful. If you weren't able to join, I wanted to just really quickly again help level set where we are in terms of reaching hepatitis C elimination, and then also just as well hone in on the FQHC and SSP panels and providing some contextual information. Next slide. So again, we'll just give you another rehash of yesterday about progress towards Hep C elimination. Next slide. So this is that good news I started out with, showing that in terms of our target of reaching Hep C elimination and reducing HCV-related deaths by 65% by 2030, we're actually on track presently. So the green bars represent HCV-related deaths by year, and you can see that it's gradually downtrending and remains below the dotted line, which represents our target. Though, next slide. I think this slide really injects more humbling reality to what we're facing in terms of the huge challenge of, while we may be experiencing decreasing number of HCV-related deaths, we are continuing to have increasing amounts of acute Hep C infections each year. And we have this goal of reducing an estimated new HCV infections by 90% by 2030. And that's again represented by the dotted green line, but we're in fact moving away from that target. Maybe that most recent data of 2021 might indicate we're getting close to the plateau, but we're not quite there yet. Next slide. So this slide shows an estimate of the number of people treated for hepatitis C from 2014 to 2020. And that's using national pharmacy claims data. And so you can see when DAAs were first released in 2014, there's a large surge in the number of people who were treated, likely representing people who had been waiting for treatment that, once you open the floodgates, you have a ton of people getting treated. We see that increasing into 2015, but then starting to gradually trickle down over time. And this may be related to a combination of, because the drugs were expensive, payers implementing restrictions in place to prioritize allocation of treatment to the sickest people, but it may also represent challenges in reaching the people who are more difficult to reach, such as those without access to insurance or those with other comorbidities. And so this remaining cohort of people that need to be treated may become increasingly more difficult to reach. And more concerningly is that we see that number significantly decrease in 2020, though that may be in part due to the disruptions of the COVID-19 pandemic. Next slide. So this is a slide that shows our care cascade using national laboratory data. So we can estimate the number of people who were ever infected, which is indicated by having a Hep C antibody that is positive, which is represented by the column on the left. So among that group, we can then estimate how many received RNA viral testing to assess for current infection. So an estimated 88% of those that were Hep C antibody positive then had at least one viral test, which, while not 100%, is not bad. Among those tested for infection with Hep C RNA, an estimated 69% had an initial infection. Then among those with initial infection, only 34% had a subsequent negative HCV RNA test, which suggested viral clearance. Now, people can be treated or cured, treated and cured, or naturally clear the virus. About 30% of those initially infected can spontaneously clear their infection. And then it's also possible that there are people who were treated and cured, but did not get follow-up sustained virologic testing at 12 weeks to be counted as virally cleared. But 34% is still quite a bit short of our target of 80% to reach elimination goals. If you look at that last column, this represents documented, to the right of documented viral clearance. This column represents after having initially cleared with a negative Hep C RNA test, then subsequently having a positive Hep C RNA test, which suggests potentially reinfection. I'd say overall, if you look at the sum of these data, it suggests we've made progress, but there's still a lot of people who are not getting tested and treated despite having diagnosed infection. Next slide. And then if we hone in further, looking at that viral clearance proportion, and we break that up by age and Medicaid, we see that younger people and then those with Medicaid are less likely to have viral clearance compared to commercial Medicaid or Medicare or older populations. Next slide. Another really concerning thing is the fact that we would expect that someone who is diagnosed with hepatitis C would be able to be treated within a year of their diagnosis, but in fact, it's actually only a minority of people. If we look and further break that down by insurance coverage type, we see even among commercially insured populations, only 35% actually get treated within a year of their initial diagnosis. If we look at Medicare and even Medicaid populations, that numbers drop down to 28% and 23% respectively. Next slide. So all these prior pieces of data come together in this slide, which shows using NHANES data, national survey data, what the hepatitis C prevalence is and our estimate of the number of people infected with hepatitis C. And if you see from the two time periods from 2013 to 2016 compared to 2017 to 2020, we see in fact that we have about the same number of people infected with hepatitis C, suggesting that while we're scaling up treatment, it's not quite at a rate that's fast enough to counteract the number of increased infections that we're seeing. Next slide. So just putting it together in transitioning now rather into focusing on these high impact settings for hepatitis C testing and treatment. Next slide. So yesterday we had a chance to talk about MOUD programs as well as departments of corrections. And today the focus will be on FQHCs and SSPs. Next slide. Again, just some brief information about FQHCs. They're wonderful places that provide care to underserved populations. An estimated 30 million people see FQHCs, receive care at an FQHC each year. And these patients are more likely to either be uninsured, underinsured, or have Medicaid. And then most pertinent, of course, to the convening is that these underserved populations that FQHCs care for are at highest risk for, or at higher risk for hepatitis C. Next slide. So these are some numbers. Again, this is a line graph that shows data from HRSA's uniform data system, which shows the number of people with a hepatitis C diagnosis seen each year, as well as the number of hepatitis C tests. And so we can see, thankfully, we're seeing an increase in the amount of tests, but then the number of people with a hepatitis C diagnostic code is going down. Now, that could be related to either more people getting treated and cured, or in fact, just we aren't seeing and caring for enough people with hepatitis C. And based on that prior data, we would suspect it's the latter. Next slide. And then let's look at SSPs. So SSPs, of course, provide essential care for people who inject drugs and have decades of research showing their effectiveness. We estimate there's about 3.7 people who inject drugs nationally. and based on some surveillance data, we estimate that half of them receive services from an SSP in the past year. And then about half of SSPs report offering hepatitis C testing. And that's really important because this is a population that has a very high prevalence of hepatitis C, ranging from 15 to 40% depending on the study. Next slide. And then this is lastly, again, a slide demonstrating where publicly reported SSPs are who submit information to a database from NASN. And we can see that they're clustered quite heavily more on the coast and in some areas with some notable gaps in rural areas. Just as a reminder in that there is a very disparate landscape for SSPs. And so as you'll hear, in addition for it to be difficult to implement Hep C testing and treatment and SSP, which it can be done, but requires extra thoughtfulness, overall, we'd love to see more SSPs providing harm reduction nationally. Next slide. And that's it. So I'd like to then transition it over to my colleagues, Mona Dashani and others who will be able to help introduce this next panel on FQHCs.